Hello everyone, welcome back to the series of lectures in nephrology. In the last session, we had dealt with your approach to glomerular disorders. In today's session, we will be discussing about nephritic syndromes. So let's begin. So the first nephritic syndrome that you should be aware of is your post-streptococcal glomerulonephritis. Right? So post-streptococcal glomerulonephritis is a disorder that occurs, as the name suggests, after your streptococcal infection. Now, just to remind you of what we have covered in the last session, glomerulonephritis, if you speak of, it presents as a nephritic syndrome. So a nephritic syndrome has what characteristic clinical features? It will have a hematuria. Hematuria is of glomerular origin. So you can have dysmorphic RBCs, acanthocytes or RBC casts. You can have proteinuria. And you can have hypertension. So you can have hematuria, you can have proteinuria, you can have hypertension, AKI and oliguria. Okay. So childhood onset PSGN usually occurs due to infection of your gas or your group A streptococci, which is your group A streptococci. So this happens usually 2 to 4 weeks after a throat infection or 4 to 6 weeks after a skin infection. So 2 to 4 weeks after a throat infection or 4 to 6 weeks after your skin infection, which is nothing but your impetigo. So what happens is that whenever there is an infection, there are some antibodies which are produced to fight against these infections, right? But these antibodies are autoreactive and they react against the glomerulus. Okay, they react against the glomerulus, and that is the reason why you develop this post-streptococcal glomerulonephritis. Okay, so most of the time in your childhood onset PSGN, the prognosis is very good. So the prognosis is very good, and the treatment mainly involves conservative measures, right? Treatment mainly involves conservative measures. So a child, most often, if he presents with history of cola-colored urine or minimal periodic edema, on evaluation he is having hypertension and some amount of glomerular hematuria, proteinuria, then you diagnose him with PSGN. Okay, and most of the time it has a good prognosis and the management is conservative. That means if the BP is high, you give them ACE ARBs, ACE inhibitors or ARBs. So these ACE inhibitors or ARBs also help in reducing the proteinuria to some extent as well. Hydrate him well. Now, on follow-up, what happens is that 1 week later you see the complement levels. Why? Because we have discussed that in your previous approach to glomerulonephritis chapter that there can be an deposition of immunoglobulin G and C3 in the kidneys, right? So what happens to the serum complement levels? The serum complement levels will be low because of this immunological reaction that happens to these antigens of the streptococci, which cross-react with some of the kidney antibodies or which cross-react with some of the antigens in the kidneys. You can have immunoglobulin and complement deposition in the kidneys. So the serum complement will be low in these patients, right? On follow-up, if the serum complement continues to be low, then this is an indication of a renal biopsy. That means what? If you are clinically diagnosing a child with post-streptococcal glomerulonephritis, there is no need of a renal biopsy, no need of a immediate renal biopsy, right? You treat them conservatively initially, right? Another very important test that you perform for the diagnosis of this is your ASLO titer. Your ASLO titer will be elevated. So a patient or a young boy presenting after maybe a sore throat or skin infection, presenting with your passage of cola-colored urine with hypertension or minimal proteinuria, with ASLO titers elevated, then you directly diagnose him as PSGN and there is no need for an immediate biopsy. Only on follow-up, if the complement levels are persistently low, then you go ahead and do a biopsy. Okay? So the prognosis is very, very good in your childhood onset PSGN. Now, in your adult onset, if it is a child, it is a different story. If it is an adult, then most of the time this is called your infection-related glomerulonephritis or IRGN. This is your infection-related glomerulonephritis or your IRGN. So this is usually associated with what? With multi-drug resistant Staphylococcus aureus. With your multi-drug resistant staph. It's more commonly seen with immunodeficient people. In patients on chronic long-term steroids who have got a staph infection, or immunological disorders like rheumatoid arthritis, SLE, or patient on cancer chemotherapy. These are all immunodeficient patients. So in these patients with associated staph infection, you can have IRGM. So this does not have an incubation period, unlike your childhood onset PSGM. This presents as a rapidly progressive renal failure. This is very rapid, very rapidly progressive renal failure, and the prognosis is often poor. So very often you have to initiate them on hemodialysis. Okay. So this is about your childhood onset versus your adult onset post-streptococcal glomerulonephritis. Now let us understand how does this PSGN behave on your biopsy. So we have already learnt in our approach to nephritic syndromes that once you have made a clinical diagnosis, the next step is to definitely do a renal biopsy. Only in your childhood onset PSGN you can wait and watch and treat for the same. You treat your streptococcal pharyngitis. If it was not treated and patient is still symptomatic, give them ACE ARBs and adequately hydrate them and watch for improvement. But in adults you have to do an immediate renal biopsy. So what do you see on a light microscopic examination? On a light microscopic examination you will see that the glomeruli will be enlarged. There can be some amount of inflammatory material. within the glomeruli. And you can have some mesangial hypercellularity as well. So there will be glomerular hypercellularity, glomerular enlargement and mesangial hypercellularity. Okay. In your immunofluorescence, you will have a granular pattern. Of immunoglobulin G and complements. In your electron microscopy, this is what you will see. So this is nothing but your podocyte or your visceral epithelial cells. Okay, this is your endothelial cells, this is your mesangium, right? So in your post-streptococcal glomerulonephritis, you can have deposits in your subepithelial as well as subendothelial, and you can have mesangial deposits as well. So the mesangium, subendothelial and subepithelial deposits are found. So subepithelial plus subendothelial plus mesangial deposits of immunoglobulin G and C3 are found. Right? So this is what we call as your starry sky pattern, or on your electron microscopy it gives rise to your lumpy bumpy appearance. So starry sky pattern is your immunofluorescence pattern of granular pattern, and your lumpy bumpy appearance is seen in your electron microscope. Okay, can you see here? These are your humps. Fine. So this is about your post-streptococcal glomerulonephritis. We have understood how does it present in childhood, how does it present in adulthood, and what are the biopsy findings and how do you manage both of it. Let us move on to the next type of nephritic syndrome. This is your IgA nephropathy. Okay. So what is your IgA nephropathy? So this is the most common type of primary glomerulonephritis. So IgA nephropathy is also called as Berger's disease. It is also called as Berger's disease, right? So what happens, the basic pathophysiology is that there is defective galactosylation of polymeric IgA. So here actually the kidney happens to be a innocent bystander. So there is defective galactosylation of polymeric IgAs. Polymeric IgAs, as we know, they are produced in the gut. So these polymeric IgAs are not galactosylated properly. So because of this, what happens is that these polymeric IgAs then go and attack the kidney, right? They go and attack the kidney. And this is what results in your IgA nephropathy. Okay. So most of the time, 1/3 of the cases of IgA nephropathy can be benign and 1/3 of the cases can progress to CKD. So what are the associations? IgA nephropathy can occur as a separate entity, but in some situations IgA nephropathy can occur due to increased polymeric IgA, which is seen in your celiac disease or your Whipple's disease, right? So whenever there is a malabsorption such as celiac disease or Whipple's disease. Apart from that, even inflammatory bowel disease and the rheumatologic condition which is associated with IgA nephropathy is your spondyloarthropathies. It's your spondyloarthropathies. What are your spondyloarthropathies? It is your ankylosing spondylosis, reactive arthritis, and your psoriatic arthritis, right? So this is about your pathophysiology and associations of IgA nephropathy. Now, let us understand the clinical features of IgA nephropathy. Let us understand the clinical features. So this usually begins at the age of around 10 to 20 years of age. And the most important clinical feature is this presence of recurrent macroscopic hematuria. They present with recurrent macroscopic hematuria, multiple episodes of hematuria when they get up in the morning. So recurrent episodes of macroscopic hematuria. Most of the time these episodes are symphalangitic. So most of the time an upper respiratory infection is what triggers this IgA nephropathy. Then sometimes it can progress to a nephrotic syndrome, but that is very rare. 1/3 of the cases can progress to a CKD and very few, up to just around 1%, can present with your rapidly progressive glomerulonephritis. But most of the time they present as recurrent macroscopic hematuria. Now, what are the biopsy findings of IgA nephropathy? The biopsy findings, as you can see here on the light microscopy, you will just have mesangial expansion. On the immunofluorescence, you may detect IgA deposition in a granular pattern. Okay. Under the electron microscopy, you can see that the deposits are predominantly mesangial deposits. Right? It is not subepithelial, it is not subendothelial. It is predominantly only mesangial deposits of IgA. So, one score that we used, which is used for the prognostication of your IgA nephropathy, is your MEST-C score. So, what does the MEST-C score stands for? It stands for mesangial hypercellularity, endocapillary hypercellularity, sclerosis, tubular atrophy, and crescents. Okay. So, mesangial hypercellularity, endocapillary hypercellularity, sclerosis, tubular atrophy, and crescents. So, these are basically the different types of biopsy findings that you can find in IgA nephropathy. So, if you take this kidney and this is your glomerulus, sometimes the parietal epithelial cells can proliferate to form a crescent shape pattern, and this causes a collapse of the glomerulus, right? So, this parietal epithelial cells can proliferate and cause a collapse of the glomerulus, and this is what we call as a collapsing glomerulopathy or a crescent. And most of the time the presence of a crescent is a very poor prognosis, and it can lead to rapidly progressive renal failure. This is your crescentic glomerulonephritis or your rapidly progressive renal failure. So, as you can see on the biopsy, mesangial hypercellularity, endocapillary hypercellularity is okay. But if there is sclerosis, tubular atrophy and formation of crescents, then it portends a poor prognosis. So, each of these, if it is present, it is given a score and we decide on a MEST-C score. So, the MEST-C score is used for your prognostication for your IgA nephropathy based on your biopsy findings. Fine. So, how do you treat? So, the most important thing is that IgA nephropathy most often you have to treat conservatively, And to decrease the proteinuria, you can give ACE inhibitors or angiotensin receptor blockers. So, IgA nephropathy is managed conservatively. You give ACE inhibitors, ARBs to decrease the proteinuria, decrease the hypertension. What are the conditions where you need to give steroids? What are the conditions where you may require a steroid? So, there is rapidly progressive renal failure. There is a high E score. And the patient is having a progressive decline in the GFR. So, these are the conditions where steroids are indicated in IgA nephropathy. Okay. So, this brings us to the ending of the understanding of IgA nephropathy. Right. So, IgA nephropathy, what all have we learned? We have learned about its associations, pathophysiology, we have learned the clinical features, MEST C-score and the management. Now, let us move on to the next type of acute nephritic syndromes. So, this is your membranoproliferative glomerulonephritis, right? So, these patterns are not only your clinical patterns, these names are based on your microscopic and biopsy patterns. So, next pattern is your membranoproliferative glomerulonephritis. So, if you can see here, MPGN is classified into 3 types. So, we have the type 1. Type 1 is the most common type of MPGN. Most of the time it is idiopathic. It can be due to infections like subacute bacterial endocarditis, hepatitis B, C, fungal and parasitic infections. Autoimmune diseases like SLE and cryoglobulinemia, Sjogren's disease. Monoclonal gammopathies and solid organ malignancies, especially lung, breast and ovary. So, this is your type 1 MPGN. In type 2 MPGN, it predominantly involves what? It predominantly involves your glomerular basement membrane. It is your glomerular basement membrane, right? In your type 2 MPGN, we have the dense deposit disease. And the associations of this is that there can be partial lipodystrophy of the face, right? So, one half of the face is having a lipodystrophy or a lipoatrophy. One half of the face is having atrophy because the subcutaneous fat is lost, and it can also be associated with a retinal drusen. Drusen is nothing but the changes which are seen in your retina, which are droplet-like figures seen in the retina. This is your retinal drusen. So, retinal drusen partial lipodystrophy is associated with dense deposit disease where, as the name suggests, there are deposits in your glomerular basement membrane. So, this is your type 2 MPGN. Type 3 MPGN is idiopathic. Okay. Then we have a specific group which was initially classified under type 2 MPGN itself, where there is deposition of C3, there is deposition of only complements. This is your C3 dominant deposition diseases, okay, which is your C3 glomerulonephritis and your C3 dominant deposition diseases. So, what have we learned here? Till now, we have learned that MPGN is basically a biopsy pattern. Based on the pattern, it can be divided into 3 types, type 1, type 2 and type 3. Type 1 is your most common and there are a number of causes under your type 1. Type 2 is predominantly involving the glomerular basement membrane, and type 3 is pauci-immune. It is pauci-immune, okay. And your C3 deposition disease was initially classified as type 2, where there is deposition of complements. Fine, okay. So, on your light microscopy, what will you see? As you can see that it is a membranoproliferative or a mesangioproliferative. So, there will be expansion of both mesangium and the glomeruli. In your immunofluorescence, you will have monoclonal or polyclonal deposition of immunoglobulin G and C3. In your electron microscopic finding, as you can see here, you predominantly have subendothelial deposit. You have subendothelial deposit, and this results in what we call as your tram track appearance. It results in your tram track appearance. So, the glomerular basement membrane appears splitting of the GBM. But the deposits are not in the GBM, that's why it's not a GBM disease. So, this results in your tram tracking or your subendothelial deposits are seen. Okay. So, this is about your membranoproliferative glomerulonephritis. So, with this we have understood all the patterns of acute nephritic syndromes. We have learnt about PSGN, IRGN, we have learnt about IgA nephropathy and MPGN. In the next session, we will be discussing about the various patterns of nephrotic syndromes. Thank you.